I'd like to thank Dr. Reddy for doing an amazing job with this. So let me start off by saying that. And if I may, slide number 1. Welcome and thank you for being with us today as we celebrate the 11th annual Vijay, Babu, Rayudu Quality Improvement and Patient Safety Day. We are grateful to have with us today 3 members of the Rayudu family: Dr. Sridhar Rayudu, Dr. Subbu Rayudu, and Dr. Paru Rayudu. Thank you very much for your sponsorship. We're also honored to have Dean Emerita Betty Dries, Dr. Dries, Dean Dries, Dean Emerita Mary Ann Jackson, and our Rayudu Endowed Chair for Patient Safety, Dr. Mamta Reddy. We also have to thank our talented students, residents, fellows, and faculty who have joined us to learn, be inspired, and commit to support the goals of the UMKC School of Medicine Quality Improvement and Patient Safety Consortium. How do I My name is Alex Norbash. I'm the Dean of the Medical School. I've been here starting March 11th, so please forgive me if I make any missteps. We gather today to celebrate the culmination of months of hard work, dedication, and innovation in patient safety scholarship from our remarkable community of learners. To those of you who participated in this morning's welcome breakfast and poster presentation sessions, thank you for your engagement and your visible display of leadership that has made today's activities possible. Following our keynote presentation, I hope you will remain in this theater for the oral platform presentations that will feature the top 4 projects selected from a total of 47 scientific abstracts submitted. The afternoon program will conclude with the QUIPS Awards and Recognition Ceremony, where the top scoring projects from the poster presentation sessions will be announced, as well as other honors recognizing both learners and faculty. For some background on today's events, the QUIPS Consortium was founded in 2014 and is comprised of our affiliate programs that serve the UMKC School of Medicine, all represented in today's display of scholarship excellence. I'm sorry.
Maybe just use this. That might be flaky. Just do the right arrow.
Will do. So, the UMKC QUIPS, thank you very much, Dr. Reddy. The QUIPS Consortium mission is to lead in the scholarship and dissemination of local, regional, and national activities directed at enhancing quality improvement and patient safety initiatives. The goals of the consortium include 1, the development of QUIPS curricula to support future clinical practice, and 2, to expand infrastructure to facilitate collaboration, communication, scholarship development, and sharing that will improve quality and safety in the local and national healthcare community. And so part of this is the creation of a culture that infuses the entire organization, where we're all committed to being data-driven and committed towards quality improvement and patient safety, recognizing there are flaws in individual education, but systemic and collective approaches to learning collectively, that's a permanent difference, and it changes the trajectory of healthcare. It affects us culturally in a positive way, and it affects us individually in terms of the professional context of what we do. Past keynote presenters. Each year, this program features a highly esteemed expert guest speaker who continues to make valuable strides in sustaining the healthcare system through their outstanding work in this field. And with that, it is my honor to introduce you to Dr. Julie Euler. Dr. Euler is a professor and associate program director at the University of Chicago Internal Medicine Residency Program. She completed her undergraduate education at Stanford University and her medical degree, internal medicine residency, and chief residency at the University of Chicago. Dr. Euler is currently co-director for the Healthcare Delivery Improvement Science track at the University of Chicago's Pritzker School of Medicine, which was developed to train medical student leaders in quality improvement and patient safety. Dr. Euler teaches quality improvement and patient safety for the AAMC Teach for Quality program, the Society of Hospital Medicine's Quality and Safety Educator Academy, and the American College of Physicians Advanced QI program. She practices as a primary care provider on the south side of Chicago. She has been the chair of the University of Chicago Department of Medicine Women's Committee since 2017 and has led initiatives like increasing the presence of women on the walls and increasing awards given to female faculty and academics. I feel very honored that Dr. Euler has accepted our invitation to present our keynote address today. Dr. Euler, welcome to the UMKC School of Medicine, and I thank you for leading off this important day for us.
Well, I am really excited to be here. It's such an honor. As I've shared with many of you, I have a few hats at the University of Chicago, but one of them, since 2006, I have been assigned to read the UMKC applications for internal medicine residency at the University of Chicago. Purely alphabetical. I also read the University of Kentucky. We know at the University of Chicago when we read the UMKC applications that you students, these mentors are really exceptional. The students that we get from UMKC come with such expertise in quality improvement and patient safety, so it's really my honor to come today and share with you some discussion around QI coaching across the continuum. So I'm going to be talking about my work in educating our students, residents, trainees later today in your consortium. Today I'm really going to be addressing coachees and coaches in quality improvement about some structural things that we can do to improve QI coaching across the continuum. So I'm excited to jump right into that. And I'm really honored to have the family here with us, Babu's family, and to meet you. We have a quality improvement patient safety symposium at the University of Chicago, but it doesn't have this personal connection that yours has, and I really love that there is like meaning in like why we're doing the work, because I do believe that quality improvement and patient safety comes from that meaning, and finding that meaning in medicine is so important to all of us. So this is the goal for the presentation. I'm trying to understand the difference between coaching and mentoring in quality improvement and globally, and trying to know how to coach a learner or be a learner in quality improvement work. Selecting a quality improvement coaching strategy. There's a few that I will present to you, and I'm excited that there are both coaches and coachees in the room, because I know that these coachees will be future coaches in quality improvement and hopefully use these techniques too. And how to coach trainees into choosing feasible quality improvement projects, motivating trainees to present or publish their work, and this symposium is a great opportunity and launching pad for that. And then talking about pitfalls for mentors and mentees. And I'll just tell you that I kind of fell into this work, as many of us did who started very early. I graduated from my chief residency. There was this new ACGME requirement, practice-based learning and improvement and systems-based practice. And they said, you could have this role as an educator if you will teach our residents quality improvement and patient safety. So I had no training except for the mentorship of my surrounding faculty and the IHI Open School educators that were kind of forming at that time in 2006. So it's really been a growth area for me to kind of jump into this work. I did not, start medical school knowing anything about quality improvement and patient safety, but it's been a true joy to learn about it and to have been coaching QI projects across the University of Chicago and nationally now with some of the, as the national organizations are trying to teach this. But the first thing we're going to talk about is this outline, and that is developing QI expertise yourself, selecting a coaching strategy, choosing projects, how to choose projects, organizing opportunities to present the work, how to reflect and improve, and also these tips. So developing QI expertise for yourself, this is something that all of you in the room are already doing. And the real thing, if you're going to be a coach, is to really do the work before you try to help others through the work. I think sometimes, as myself, I was thrown into it, as a coach or a mentor. And those of you who are coachees and are doing this work, you know that you are going to be a better coach having done the work yourself. Very important aspect of it. And there's this mantra of learn, we used to say see one, do one, teach one. And in QI, we say learn and then see, practice, prove, do, and maintain. And there's this like continuous cycle that we do. I should say that Dr. Warm and I from Cincinnati, we use some of these slides to teach quality improvement through the Society of Hospital Medicine. So the first like 10 or 15 slides, we worked together and he developed them, and then the rest I have worked through as we did our work together. So, all right. And so there are some of these techniques I've seen the students and the residents using already, but when you're doing improvement work, there are so many different types of improvement work you can do. I've seen a lot of PDSA cycles today in your presentations. I've seen lots of run and control charts, which is really impressive because I think at a student level, understanding what a run chart is very, very impressive. I'd say most people who come into my residency program don't know what that is. And you'll see just a lot of these common terms of what you can do to get yourself involved in QI work. And then the other thing is understanding the frameworks, the improvement frameworks. We at the University of Chicago use one that I'll share with you, but there are so many improvement
Recording
frameworks.
in progress.
It's okay, it's okay. No problem. I'll just approve it and move on. When you're an educator, you can like roll with anything, yeah. And so really these are kind of the underpinnings, so that the QI work done at UMKC is the same as the one done at the University of Chicago, because we all are using some common framework. And I think that's a really important part of developing QI expertise for yourself. So at the University of Chicago, we use the IHI's model for improvement. I saw many of these reflected in your presentations today. The aim statement, what we're trying to accomplish, how we know that a change is an improvement, making sure that we're picking measures that are valuable, and like what are we going to implement to do this plan, do, study cycle. There are other programs that use lean, and so there are aspects of lean, I think, that are also really important. Places like University of Michigan, for instance, use lean. I think lean was primarily created around the manufacturing plant. In addition to the Six Sigma, it has to do with the amount of error that you want, and so it depends on what kind of project you're doing, on what kind of framework you're using. But as long as you're familiar with one of these frameworks, I think that's really important to be both a coach and a coachee. So really the model for improvement focuses on asking the right questions. Lean is really like reducing waste in the system, which I think we haven't really tackled in healthcare yet, but I know this new generation will. And then Six Sigma is really reducing those errors. So just picking a framework, getting familiar with it, and using it as you coach. And then the next thing is keeping a coach for yourself. So many of us, this aspect of coaching is new. So I have newly had a coach, and I think what I've learned is a coach is really to help you become that better person or help your QI project become better. And a coach is really about asking questions. And so I've intermittently had a coach in my life, but it has made me better in QI when I've had a coach, both a personal coach and an academic coach. But I think that's an important aspect. And coaching done well might be the most important intervention designed for human performance, because it helps you achieve what you want to achieve, whether that's a personal thing or in QI. The next thing is selecting a coaching strategy, and really the important thing here is to be deliberate. Sometimes if you don't know where you're going, you might end up someplace else. Now sometimes that's the beauty of life. Life is messy and we end up other places. But if we really want to be deliberate about our coaching, I think it's a really important thing to choose a strategy. And so this slide really just differentiates between what a coach is and what a mentor is. And you can see on the x-axis, really, this is the client as the expert. So on the left-hand side, the client is the expert. On the right-hand side, you, the coach, or whoever, the mentor, is the expert. And then on the y-axis, there's the tending towards the person is the giver of answers, and versus the person asking questions. And you can see that if you're a manager, I'm your boss. I am giving you the answers, and I am the expert, and I'm telling you what to do. And that is generally not what we use in QI. QI can either be a mentor who maybe has a little bit more expertise, but is both asking questions and giving answers, or a coach who needs to have maybe less of the answers, less be the expert, and more of the question asker. And that's what I really love about your program here. It seems like the sponsors are kind of growing with the sponsees, and they're all learning QI together. And I think that is a much more natural way. As a coach, these people are coaches, and really you don't have to be the QI expert. You're asking questions, you're drawing somebody out, you're learning what they want to do. And so I think coaching has been much more popular because somebody doesn't have to be the expert to really help somebody achieve their goals in QI or elsewhere. So I love this slide for that. And this is another slide just talking about the coach versus the mentor. And you can see the most important thing is the middle, that both require exceptional listening. One, the coach is more raising self-awareness, and mentor is more like sharing their experience, but both of them really take exceptional listening. So the beginning of this talk will be about coaching, and the end will be about mentoring. But I really think this at the bottom is important, is like the mentor we talked about is generally the expert, and the coach is usually, the learner is the expert in what they want to accomplish and what they want to do. And so that is how we kind of differentiate between coach and mentor. And that makes the point of the exceptional listening in the middle. So the self-determination theory, there's basically 3 human needs. There's competence, autonomy, and relatedness. Competence is you need to be effective in dealing with the environment, and I think that is an important aspect that we're all growing in, but especially in your medical training early on. The next thing is autonomy. We want kind of control of our lives. And that is an important aspect. And relatedness. We need to have relationships with each other. And I think that in these 3 things, the experience of autonomy, competence, and relationship really fosters kind of motivation and engagement and results in enhanced performance, persistence, and creativity. And that's what we're trying to get at in quality improvement, is to kind of use the kind of needs of what people have to foster this persistence and creativity and quality improvement. And so the next thing we're going to be moving towards is selecting a coaching strategy. I'm going to go through each one of these 5 aspects of it. The first one is the coach structure and process, then the relational skills, the coaching skills, coaching theory and models, and then coach development. So each one of these will be a kind of one aspect that we're working on. So the coaching structure and process usually is like we are agreeing to be a team together. Like this structure that you have kind of sets that up, but this will not always be the case when you leave UMKC. But the agreement is really important. Like, how long are we going to work together? What is our mutual goal? What do we both want to get out of this? And then really determining how often we're going to meet is a really important thing. I think sometimes, I don't know if the trainees or the students, but like, when is our next meeting? If we don't set that up, we don't have an expectation, it's kind of like left nebulous, and then it might not happen, and then the relationship might not happen, and the project might not happen. So I get really practical in here, and like I think that is really important. How often are we going to meet? Plain and simple. And then also managing the process and accountability. I think so often we start into a project like this person on the top, we have an expectation, we think straight to success. But reality is that we like start, and then like life happens, and we're going around and working on the project, and then eventually we achieve success. But so setting that accountability and during that process is really important. So the next thing is relational skills, and I think either a coach or a mentor, relational skills are really important. And so the first thing is really establishing a meaningful coaching relationship, working on effective communication, and cultivating the trainee's emotional intelligence. And I think that's this bottom cycle of self-awareness, self-regulation, empathy, motivation, and social skills. So it's interesting in QI, I'm not teaching you about PDSA cycles, and I'm not teaching you about aim statements. That is a really important part, but I think half of being a good coach and a coachee is really about navigating relationships and relationships in life. And so we teach that as a really important aspect of coaching. So the next thing I'm going to get into is these models. There are 2 coaching models that we teach. One is the R2-C2 model. And you can see that the R2C2 is basically stands for these 2 R's and these 2 C's in this like concentric circles. And so I'm going to go through each one of these. And again, it really does focus on relationship building. And so rapport and relationship building is not every time, not just in the first meeting. So when I do coaching both in QI through ACP, the American College of Physicians, and they have like just a general resident coaching. And the first thing is not like, tell me about your QI project. It's, how was your week? What's going on in your life? What can I do for you? So look, there's that connection there. And I think that makes the best coaches and mentors, that it's not jumping right in, but that it's like a relationship building first. And that also helps you to recognize and celebrate successes in life. Like just hearing from sometimes, maybe this has happened to you, that a faculty member just talks about, what they want to talk about and doesn't leave time for the trainee to listen to the trainee, what's important to the trainee first. And I think when you're coaching and becoming a future coach, hearing from the trainee first is really important. Like, what do they value in this QI project or in their lives? And then confirm, empathize, showing respect, building trust is a really important thing. So the first thing is rapport building. And then the next thing is really these reactions. And then, so there are many reactions that you have to quality improvement. Sometimes they're frustrations. So I will say that as I work with residents on QI projects, I first start with negative reactions, like tell me what frustrates you. Tell me what annoys you in the hospital. Tell me what's not working. Tell me what drives you crazy. Tell me what, if you could fix, your life would be better. And I think hearing those things and then making something positive about them is what has kept me in quality improvement education for so many years, because it kind of gives the trainee some autonomy to make changes to things that frustrates them. And then also exploring the reasons for the reactions and validating experiences is really important. The next thing, moving on, is the content. And in the content, you really want to look at the facts and the details, and then look at patterns. And I think that that you're drawing out in that quality improvement project, what are patterns that you're looking at, and how could we put those patterns together to make something practical together. So that's a really important thing. And then the next thing is really this coaching for change. And I think this is really the key step here. And so the most important thing for the coach is understanding that you're tailoring what you're doing to the trainee's insights. And you can see in this graph, this table, that there are different types of people that will come as you are the coach. Some people have low insight and low adaptability. So for me, these are trainees or residents that are like, I don't really want to be here in your QI class. I don't really want to fix something. I have to do this. This is like a checkbox on my training. And so sometimes they're not really wanting to change. And then there's people who are like, oh, okay, I didn't realize I had to do this. I didn't realize it was part of my education. But now that I'm here, I'm going to like work with you and make something better. And then there are the next set, the next column, which is probably this, the trainees in this room, which are the people that are very high insight in what needs to change and are very adaptable. But if you are the coach, you need to be aware of like where your trainee falls in these categories and how to tailor your approach to them. And so, and that to me is like, these people need very concrete measures and consequences. I'm like, this is part of your evaluation and your residency program. Like, next time we're going to check what your role, and did you do what you said you were going to do? These people, like, basically, they like need to set them on a path, and they're like, they bring back a ton of stuff to me, and all I need to do is like set them up with the right people. And so as the coach, you really need to like understand who you're working with. And the idea is to help the trainees move, of course, from the I don't really want to be here to the like highly motivated. And I think that there are aspects techniques that you can use as a coach to move people in that direction. And for me, what has been is like when they're able to see a little bit of success, like, oh, that thing really annoyed me, and I was able to kind of make a change in that in the last 6 months. Do you know what I mean? It's those successes, like even though I had to be there, like I'm a little bit proud of that. But I still had to be there. So that is the goal.
And then the next kind of coaching strategy we're going to talk about is master adaptive learners. And so there is this excellent book about master adaptive learning in coaching and medical education. And it's basically making people who are always adapting and always learning. And it does help our residents and students overcome challenges with collaboration. And so the Master Adaptive Learner Framework has to do with these 4 kind of interwoven wheels. It's a little bit like a PDSA cycle. Ironically, this is a coaching strategy, but when I look at it, I kind of see a PDSA cycle here. So I overlay it on each other. So there's this planning aspect of it. There's this learning aspect, there's assessing the learner and how you're teaching and coaching, and then there's adjusting to what the trainee needs. And it's really this metacognitive approach based on self-regulation and adaptive expertise and practice. And so I think for me, it's getting into the details of kind of adjusting to the learners. That is when I use Master Adaptive Learner. In all honesty, I will say that I tend to use the R2C2 model more than the Master Adaptive Learner. Like, I'm a very concrete QI person, and the Master Adaptive Learner is amazing, but it's a little theoretical for me. So I wanted to present it to you so I could show you 2 frameworks. But I mostly use the R2C2 model here. So you can see, I kind of talked about this already, that in planning, you're questioning and helping the coachee prioritize, goal setting, and then you move on to kind of critical appraisal, like what are we looking at, what kind of learning strategy should I use, and then you're in assessing, looking at the informed assessment and external feedback, and then really kind of moving into this routine versus novel application and adjusting the way that you coach to tailor to a trainee. And really, the things that you need for a Master Adaptive Learner is like this curiosity in learners, motivation, and then thinking about mindset and also resilience. And so the next step is coaching theories and models. And so really you need to use flexibility and adaptability. I think all of us know this. You need to be flexible and adaptable in medical education across. But I really love this, this idea of this tree. Like, QI is about being flexible and adaptable. Sometimes I heard some projects that had data that wasn't as successful that you hoped. But the point of QI is that you use those negative studies to then impact and influence. There was a reason why it was negative. Why? Let's look a little bit more into that. And I think that is, in coaching, really important to both validate this is an amazing success. Of course, you met your aim statement and you got your metrics down. But also, when we have a negative, result, how can we look at the details of why that happened and what resulted to that? And so I was really excited to hear both positive and kind of negative results today, because I think both of them are really important to a QI mindset. So those were the 2 coaching framework examples, and so I just want to leave you with these 2 pictures as you're thinking about, like, which one could I use in the future? These are the 2 that we present, and as I shared with you, I use the R2C2 model more. The next thing is coaching development and how to cultivate self-development and self-management. You can see that all of us are going through kind of a development in life from, I don't even know where I would be, like maybe here or here. I kind of still feel like I'm here, but I'm really not. But the idea is that we're all going through kind of transitions, but that to kind of continue to improve yourself, to always be learning and always be adjusting is really important, and also recognizing limitations, because there are limitations at each stage. And so there's a really great book that I wanted to talk about, Coaching in Medical Education. And this is not just for QI, but I think the tools could be used in QI too. There is this idea that coaching should be consistent and longitudinal over time, so that the importance of that relationship building is really a lot of the coaching. This relationship of trust. And then we're really trying in medical education to separate the supervisor evaluator from the coaching, as I think that is one challenge that I have in a role in a residency leadership, that I sometimes am the evaluator, but I'm sometimes trying to coach. And the more we can separate those things from each other are really important, because I think there's this feeling that you need to perform and do better for somebody who's evaluating you. But the idea is you're only evaluated through a certain point, and then you're a doctor, and you're not so getting evaluated, but you still want to have this mentality of improving yourself. And so kind of fostering that early on is important. And then facilitating reflection and prioritizing goals. I know I've heard even through this morning that you do a lot of that here at UMKC, but then also active listening in the coaching relationship. But I think one of the things the coaches do understand is the system and the process for how to get through, and they have like a bigger picture view than somebody who's going through the process right in front of them. And so kind of shaping and helping them coachees navigate is important. And the one thing I've learned, and I did make mistakes in the early, is don't do the work for them. So I will say, I'm going to talk about this later, but in QI projects, I still have a tendency to be like, let me take the notes for this QI project meeting. You know what I mean? And then I have them. And then I'm like, did the coachee get engaged in them? Like, why am I doing that? And so I think there's a tendency there, like the more work that a trainee does, the more they're engaged in the project. And so I think I've gotten pulled into this as a coach. I'm like, I want something to happen, and I'm like, nobody's volunteering. So I'm just now okay with silence. Like, somebody needs to take notes for this meeting. Who's that going to be? And then I just sit silently until somebody volunteers. And I say, like, we're all going to take a part in this QI project. Like, somebody's going to interview a patient. Somebody's going to, do the data management. Somebody's going to do the fishbone. Who wants to take the notes? So I think that is an important aspect that I've learned in coaching along the way, but I was pulled into early in my career. So the next step is really choosing a project. And I mean, I almost feel like you guys are experts in this because I've heard so many good QI projects today, but I think it's just good to reiterate these things. The first is alignment. And so you can see that, like, when a project is aligned with an institution goals and individual goals, it's much more streamlined. And then sometimes we feel like it's out of alignment and things are not working well. So we're going to talk about alignment first. And there's a couple things to align that you can do to improve alignment, and those have to do with these three levels: micro, meso, and macro. So the first thing I sometimes see is that we're like, hey, trainee, do this work on the side, extra, in addition to, not part of a class, not part of a responsibility, not part of a rotation. Like, this is a requirement, so can you do it? And I think that as a coach, setting that up so it's like embedded in a time when they have time to do it, when there's clear kind of time set aside, is really important, and also sometimes hard to actually get done. Engaging the clinical microsystem in the choice. So I, for instance, would say this would be like, are you working on a floor of I heard some stories in some projects in the ER, some in the clinic, some in a specific clinic, and I think asking that clinical microsystem what's important to them, as opposed to like, we're going to do this project in this area, but getting the feedback, is it right for this project, this clinic, or this area at this time, is really important. And the last thing is the goals of the healthcare system. So I've had a couple of projects where the trainees really wanted to work on this, and the hospital's like way over here talking about like length of stay and 30-day readmissions, and they don't have any resources to work on, this thing over here. But if you're able to align, for instance, I heard an opioid project today, if you're able to align opioid use disorder with like a readmissions project, or how many opioids you prescribe, then the institution is much more engaged with it. So really important as a coach to help the project align, and as a coachee to ask those questions. The next thing is really scope and setting realistic goals. I think sometimes I've had trainees are like, we're going to fix this amazing outcome that I'm like, we're never going to achieve that in your 3-year residency program or your 4-year medical school. And so really helping a trainee scope a project is really important. Part of the scoping is like who's on the team. I think sometimes there's a tendency to have teams of all physicians. I'm loving that there's like diverse learners in the room. I think I've met a pharmacist and nursing staff, and I think that's really a benefit of what happens here at UMKC. But that does not always happen when you leave. Sometimes there's a bunch of doctors sitting in a room working on a project who are not involving a more global team, and sometimes it's important to make sure you're hearing all the sides to it. And so data, I've heard a lot about data today. I know that everyone knows data is challenging. Data exists in our institutions, but sometimes it feels like we're not able to get what we want at the time that we want it. But I think the kind of role of a coach is to say, what are the sources of data? If even though we want this, could we like actually use this as a side piece of data that will help us without us doing the work? And then sometimes we just go back into the charts and do small chart reviews. Like a small pilot test of change are really important. So scoping the project for data is really important. The time, I talked a little bit about the time already, but the time is really the biggest challenge of our lives. If you ask many physicians, like, what's your biggest barrier, it's time. And so allowing some time for the team, for the coach, for the trainee to have this, I think that's been an important part. So we, for instance, in our residency program, we give the trainees 2 hours to work on it and a 1 hour meeting where there's the expectation, so that they're not like, oh, work on this at night on your extra time when you're post-call from some rotation. The other thing is communication. I didn't hear about how your projects are transitioned, but I think that it's really important. I think one of the techniques that my trainees have used is shared Google Drives has been like the common theme in so many of our QI projects. I think there's a little sensitivity about like data on Google Drive, so we use Box now at our hospital. But having like planned handovers, so if a QI project either takes a hiatus when somebody goes on some busy rotation, or it's handing over to another group of trainees, and having that be a planned handoff is important. And then dissemination, I have found, and I think that this is very clear in your symposium day, that it is kind of voiced to the trainees that it is important to disseminate, and that this counts as a dissemination. Like, this goes on your CV. And I think when people see that, like, they could both present it here and then take it to like a national meeting and show their QI work there, I think that really helps motivate. And so we really try to build this in as a coach. And so there's share frequently and often, like on your monthly meetings, but also get credit to the work in the health system, an example like this in a symposium, but also outside the health system, where we'll talk a little bit about IRB and QI determination. And so when we build in kind of dissemination to the team, we often have like mid or endpoint project presentations to educational leaders or clinical leaders and fellow trainees. So I teach an elective to our students who are not actually doing QI projects, they're just learning a theoretical QI project, but I make them present at the end because it kind of is a culmination of all the things you learned and how you put it together, and they can put it on their CV. But also to the health system. So this is this health system quality symposium I was using like example what we do, but you obviously have one, and that's a great opportunity here. Sometimes there's other medical student or resident research days, or we have a QI team that there's report out sessions that you can go to. I think this is a really important aspect, is to have like a pinpoint time where you're finishing a project and presenting it. And then outside the health system is often one of the things I'm asked to talk about. And so I don't know if you guys have talked about IRB versus QI determination, but at least at our institution, an IRB is when you're collecting any PHI or personal health information. Like if you're trying to follow one patient over time and you have their medical record number and their date of birth. But oftentimes in QI, we're using like big data sets without patients' names and without their any true PHI. And so at least at our institution, we have this QI determination where you're able to get approval to take big data sets outside the institution, but you still need approval, but it's also that you're not collecting PHI. And so I'm not sure if you have that here, I'll have to learn, but I think that's important to learn about as both a coach and a coachee. And so then we encourage trainees to go to regional meetings, and of course there are lots of national meetings that accept QI. Work with the American College of Physicians, and they're a big, huge organization that accepts a lot of QI projects. So if you're looking for places to take your projects from today, there are probably some specialized ones in the specialties that you presented, but also some larger ones. So there are also ways to publish your work, and so this is I'll share these slides. So this is a SGIM list of all the places that accept QI work with their impact factor, and the point is really there are lots of places to submit QI papers, and I really encourage you to try to do that. I think the more that we see both negative and positive studies, when I have a QI project with trainees, I'm always like, let's go look and see what was published in the literature. My current students are working on falls in the falls with injury, because that's a reportable event. And so the first thing we did was we went to the literature and we asked what other hospital systems are working on falls with injury. And so the more that we can present and share across institutions, the better. And I just wanted to bring up that when you publish QI, you need to be using these Squire guidelines. So there are guidelines for publishing research work, and these are really the guidelines for publishing QI work. And so you can see that many of the things that you had today in your work are listed here. So in these Squire 2.0 guidelines, having an aim statement is important. Like, not many research projects have aim statements, but QI projects should. And then, what were your interventions, and what kind of measures, and talking about I heard lots of these words today, so I know you know them. Process measures, balancing measures, that these are spelled out. So this is kind of the high-level guideline. So when I submit a QI work to a journal, they'll say like, oh, it needs to put it in Squire 2.0 guidelines. So just important to know about that before you submit. And the last thing that we end up with here is reflecting and improving. And I think I have found that this is something we don't often do. So reflecting and improving can be one-on-one, like a coach and a coachee. Like, how did you feel like that project went? What do we want to do next time? Are you feeling like you want to move on from this project? Or are you feeling like you want to continue this project? I sometimes think the presentation happens and we just let it go, but being specific about a conversation is important. It could also happen in a group. So I do lots of group projects with groups of residents and groups of students, and we reflect as a group, like, how do we feel like this went? Do we think we should continue it? Do we think we should abandon it? Should we change it a little bit? And the other way to reflect is on paper. So when I do QI projects with trainees, I make them fill out a form for me, and it says, like, what was your contribution to this QI project? How do you think this project could have been improved? Do you think this project will sustain? Like, how did this change your education? And I think that reflection is so fascinating, and it kind of forces the moment of learning. And then I just cut and paste that into their folders because I think it's, such good reflection. So I'm going to move on just quickly to talk about tips for mentors and mentees. And I want you to just think in your mind, what is the best mentor you ever had? And what were the strengths and weaknesses of that mentor? Because no one's perfect, right? I gave you a picture of my two mentors right here. Dr. Vinny Arora is now the dean of our medical school, and Dr. Lisa Vinci is the medical director of our clinic, and they are still my mentors 15 years later. We started teaching QI together, and their strengths were like they knew a lot about QI when I didn't, and I needed that expertise from them. They knew a lot about the institution and how it worked, and they knew the systemic knowledge. They were creative and innovative. They gave me opportunities, and I really also, just personally, their life balance looked like mine. They were also very busy, didn't always have a lot of time for me. They were stretched in lots of different areas, and they had a lot of mentees and talked very quickly. Sometimes I was like, oh my, I just had like a list of 10 things that I'm supposed to do now, and I don't have a meeting with them. So, but I have really been blessed, and I think thinking about kind of your both strengths and weaknesses of your mentors and of yourself as a mentor is really important. And you can see in this graph of fundamentals of mentoring, it's kind of a support challenge. And so if you're in this lower corner right here, if you give as a mentor low support and don't challenge a mentor, there's some stasis, like not a lot of growth. But if you give a lot of support and challenge, there's a ton of growth. And so the idea is to kind of balance the amount of support you're able to give and also how much to challenge. So that is an area. And then there's this like skill, will, coaching guide. And it's kind of the same thing as like how much skill does the coach or mentee have versus how much will do they have. And so when I have trainees who are not super engaged and they just have to go through a QI project, they're probably low will. And I either, and it depends on how much skill, and I either need to be very directive, or I need to like find a reason to motivate them, this is going to make your actual life in your clinic better if you do this work, right? But there's a lot of trainees, probably the ones in these rooms, that have both high will and are developing high skill, and really all you need to do is delegate. And so I think just figuring out kind of what the role of the coach and the coachee, or the mentor and the mentee are. And both mentoring and coaching have value in QI education. Mentoring is usually like a long relationship based, and usually coaching is shorter and task oriented, like we're kind of trying to accomplish this task together. And so I just briefly want to go through these. There were some really great articles in JAMA that talked about some of these like malpractices that mentors do and mentees do, and just like kind of acknowledging them and thinking how to manage them, I think is really important. So, and I'm not saying these are common. Like but I have, one of the things that I do at the University of Chicago is we have a track for all the students interested in quality improvement. And so they have their own mentors, but they have to, we kind of oversee them all. And so I have to also oversee the mentors. So I've seen a lot of these behaviors in mentors, and then I have to go back to the mentor and help, or I have to help the trainee to like, go back to the mentor. So I know none of you are this in this room, but it is good to acknowledge. So there's hijacker who kind of takes over the work, the mentee's like, oh, well, you of course will be the first author, even though I did all the writing of it. And so there's that type. There's the exploiter who really is like using a mentee to like do some of the kind of grunt work, but not giving them the kind of successes. And then there's a possessor who's like, you are mine and only mine, and you can't do anything else but my projects. And I think acknowledging those things, and then there's some tools to kind of acknowledge them and to manage is really important. And that was active mentoring malpractice. This is passive mentoring malpractice. So there's the bottlenecker where everything has to go through this person, but this person is kind of, wants to look at everything but doesn't have the time to look at everything. And in this way, setting firm deadlines and being clear about expectations is really important. There's a country clubber, which is really kind of, out and kind of conflict avoidant, wants to be liked, and values the social order more than the mentee's growth. And so in this way, this might be one person on your mentorship team, but not the main mentor. And then there's the world traveler who's just like kind of really never available, who's really important, but doesn't really spend that much time with the mentee. And so kind of this regular cadence of communication is really important. There's so many smiles coming from the front of the room right here. Like, there's some like identification, I feel like, going. And then I just wanted to ask the question for mentees, like, what are characteristics of a good mentee? Like, how do you become a good mentee? And what are characteristics that can make a mentee challenging? So, and I think this is really important. Like, I always think about this in clinical care. So I'm not a risk taker, but I'm also not a perfectionist, and I need to know these things about my practice, as I practice medicine. Same thing about myself as a mentee, a mentor, and a mentee for that matter. Like, I need to know what my strengths and weaknesses are. So this is like a follow-up article to this article about mentees. There's the overcommitter, and I definitely have students who do this. They're like working on this project with this mentor and this project with this mentor, but then are they really getting it all done? Now, some of them do. Some of you, I'm sure, are getting lots of stuff done, but just making sure that you're committing to the right number of projects that you can fully commit to. And then there's the ghost or the ghoster. I think this is the kind of fail to follow up on things. They're kind of busy with their personal lives or something else, or you don't hear from a mentee for a long time. And this is just like making kind of gauging your true interests. Like, you can decline if you want to. Like, you do not have to commit to that. Only commit to the things that you really want to be involved in. And then there's the doormat, and it's usually the person who's on a receiving end of a manipulating mentor. And really asking, like, is this the project that is going to align with my goals for my future? And I see it where, like, a student is working on a project and they thought they wanted to go into ER, and now they wanted to go into OB, but they're still working on this ER project. They're not sure this is good for themselves, but they don't have the confidence to be like, this project is probably not aligns with my goals anymore, And I think the confidence to do that and help, and I often end up helping the mentees to do that, is important. And then there's the confidence-lacking mentee, which I would say I was probably in when I was in medical school myself. And so this one, the vampire is like a mentee who needs constant attention, who's like constantly emailing and constantly reaching out, and just like kind of the mentor doesn't have time to answer them back. And I think with this, it's really in the mentor's responsibility to set clear boundaries. Like, you don't need to come to me for everything. You can have some independence here, and also, you know, forcing that person to like put your nickel down. And then there's a lone wolf who's like super self-motivated and but doesn't feel like they might need a mentor so much. And then this is also a kind of the relationship, going back to the relationship of like, what can you do without me and what should you do with me? So I guess I've seen a lot of mentees who like present a poster without showing it to their mentor, and we're like, your mentor needs to see that. Like, that's the lone wolf behavior. Like, your mentor needs to review that paper, like that poster. Like, maybe your mentor didn't have time, but like, there's some things you shouldn't do without running it by if you're going to put somebody's name on it. And then the backstabber. These things don't happen, so I was thinking to myself, like, I don't want to like make this negative, but some of these things sometimes do happen. So, this person is often sometimes blaming other people. So it doesn't happen that often. And so I'll just end with this. In the 10 minutes I have left, a long time ago with some of my colleagues, I talked about turning unsuccessful, because I've mentored tons of successful, but lots of unsuccessful QI projects, and how to turn those into a success. And we kind of separated into project factors, staff factors, and organizational factors. And so really thinking about, how long should this project take? Is this a 3-month project? Is it, if it's going to be a 5-year project, it's probably not the best. So like making an ideal amount of time, building in data collection, we've talked about a couple times, talking about measurement plans. Like sometimes, many of you worked on process measures, which is a really much easier kind of to make a successful QI project, versus an outcome measure that usually takes longer than you have as a mentee or coachee. Kind of assessing feasibility and impact of a project from the very beginning, making sure, as we talked about, it's aligned, the theme is aligned with the institution. And then staff factors. Some of your team sizes were big, and some of your team sizes were you and a couple other people. And I think that is really important to ask, like, what's the ideal team size for this project, like scoping it correctly. I tend to have big projects in residency programs, and then that is hard because there's like some people who are very involved, some people who are not involved at all, but how to like make sure that everybody takes a role. Faculty QI experience we've talked about, and then making sure we get all stakeholders involved. I talked about record keeping. I think I even have one more slide about record keeping, because like so important for somebody to be like taking the notes, what happened in our meetings, what did we do to push it forward. And then the organizational factors is like how to look for support for projects. Your institution seems to have good support, but like, is there any money to do these things? Are they totally like groundswell? What is the sphere of influence? I've definitely had like trainees want to work on, for instance, a cardiology project where we don't have any cardiology people on our team, and it's really hard to influence, something that happens on a cardiology floor when I'm a general internist and I'm not a hospitalist, and do you know what I mean? And so making sure that that you can impact that sphere of influence before you go into that project. The physical location, I think this related more to like sometimes our trainees, they're like at this hospital but trying to work on a project at this hospital, or they're like the project's in the clinic but they're only in that clinic every 6 weeks, so trying to like align the physical location of where it happens. I heard one that was addressing culture. I can't remember who that was, but culture is really hard to change, and I think that the presentation I heard addressed that, but kind of learning about culture change is really important. And then I've really focused in my career about top down or bottom up, and I've really wrestled with this. Is this, when you do a QI project, is it like the coach and the mentor is like, this what needs to be done, this is what we're working on, come join me? Or the hospital says, this is what we want to do? Or is it, this is what I see is not working, in the hospital or the clinic, and this is what I want to change? And I think that there's benefits to both. I think that as a QI team, you just need to discuss. I've seen a lot of engagement when it's bottom up, because they're like, this frustrates me. But also maybe in students where they haven't worked as much clinically, and then it maybe like they want mentorship within one area, and a faculty mentor can say like, this is what I'm working on, please come join me. So I think there's benefits to both, but being specific about it is important. So I usually just use this time to think about what are your strengths and weaknesses as a mentor coach. Many of you have been doing this role for the last year. Many of you are going to do this in the next year, I think. And also, all of us are both mentors and mentees, coaches and coachees. Even the senior students are mentoring junior students. So what are your strengths and weaknesses as a mentee-coachee? So I'll leave that with you to talk about. And then I think I've covered most of these things. So I want some time for questions, but we've kind of talked about these areas. And I'll just leave you with this last thing that I say every time. There's some practical things that I learned that are not really related to coaching and mentoring. But really, in your QI project, there's a recorder and a group project that takes notes. And then meetings on January 1st, we talked about this. And meetings on February 1st, we talked about this. So that you can track when you want to present it later on. When did you implement this? When did you discuss measurements? Very important. And then review expectations at the end of each team meeting. So at the end of each QI meeting, I'm like, who volunteered to do the process map? Who volunteered to do the data collection? Who volunteered to do this part of it? What are you going to do by the next time, and what am I going to do by the next time? And then taking that down and then starting the next meeting with that. I think that has been the most helpful to me as a coach and mentor in QI projects. Addressing the variable enthusiasm and responsibility of team members. I don't expect everybody to be the QI leader in a group project, but I do expect everybody to be engaged in some way. And so I need to know, what are you going to do and contribute to this QI project? That as a coach and mentor, you're respectful for outside responsibilities. When my residents go on to a MICU rotation, an ICU rotation, I'm not expecting them to do their QI work during that time. But when they come back to ambulatory, I'm like, hey, you're back on ambulatory. It's time to get going with that. And then allow for personality differences. So I think sometimes I have an introvert daughter, and I've learned so much about contributions and brainstorming, and just making sure that there's some written part of brainstorming and there's some written part of contributions. That nobody has to be I want to raise my hand and talk out loud, because there's so many good ideas that come from different personalities, and I've learned that a lot in QI. And then for the coaches and mentors, building in this project presentation, just like yours was, because I think that really makes it tangible for any level of trainee. So with that, I'll just kind of refresh you on the R2C2 model of coaching, the Master Adaptive Learner. Of course, you all know about Plan, Do, Study, Act, and I know that we'll all use the curiosity, motivation, mindset, and resilience to keep working on this. I hope that I've accomplished these learning objectives, and I'd really like to thank you. This is my family, and this picture was an old picture that was on one of my presentations. I'm like, they're not that little anymore, but they still are that little in my heart. So I hope that this has motivated you both to be great coachees and mentees and coaches and mentors. And it's been a real pleasure to talk with you, and I'd love to take any questions that you have. Do we have time for questions? We're moving on to our amazing presentations. Yes.
So when you meet with a mentee, how intentional are you about doing some of those assessments in terms of their skill and motivation? Do you put that down in some sort of formal assessment, or you just kind of do that in your head?
So in the first meetings, it's really about rapport building. Who are you? What do you want? Why are you coming to me interested in QI? And I think that the formal assessment comes in the middle, where I can assess how engaged are you? What is your participation in this QI project? So I kind of tailor it a little bit. So I'd say I mostly do group QI projects as opposed to one-on-one, and so it's more the middle. I'm recognizing participated, said anything, volunteered to do anything, contributed to the QI project. So I'm like, what do you want to do? So and so. Do you know what I mean? And then so I'm mostly tailoring it in the middle, but I'm not formal about it at the beginning. I'm much more rapport building in the R2C2 model at the beginning. Yeah. Yeah.
Thank you very much. That was awesome, and especially for this audience where you have the coach and the coachee all in the same person many of the times. Question I have for you, you mentioned about education coaching for medical students on their track versus residents, what are maybe a couple of differences you see in those two groups in your role of how you're coaching and training?
Yeah. So it's interesting when I do QI with students, what I see is like a little more innovation because they haven't gotten like into the system yet. Things work and they're like, why? That is so dumb. Like, why do you do things that way? And I love that. Do you know what I mean? And I'm also like, some things are just not possible. Like, some things I'm like, yeah, we can make that happen. And so that's the one thing that I notice is like a little more innovation in students. Residents, I'd say, are a little more like, this does not work and it's never going to work, and we're using these workarounds to get around the thing that's not working. And so what I am mostly trying to do is say, like, let's stop using the workaround and change the system to make this process better. I don't know if that answered your question, but I think that is what I see when I work with students is like a little more innovation, a little more like kind of coming from the outside, like, why do you do that way? And residents kind of like they are in the system, so they've accepted the way we do things, but they like have their workarounds to get things done. Yeah. Great. Yes.
As a non-physician or as your multidisciplinary team, how do you encourage your medical students or residents as they're pursuing QI, getting embedded into their health systems, already established either committees or structures, or there's a large amount of opportunities from a QI/PI standpoint. So how do you plug them in?
Yeah, I mean, I think one of the things is making sure interests are, so I'll give you an example. Like I'm teaching an elective right now. The students want to work on falls with injury, I think I mentioned. And what I think they've realized during the process is it's really not a physician-centric measure. It's really a nursing. And so they interviewed a whole bunch of doctors about it. The doctors were like, I don't know, I think this is what happened. But it really wasn't. When they got into like, there's a nursing team who meets weekly, who's assessing our falls with injuries. And this is the things they've implemented that the students were like, kind of eyes opened and now participating in this falls with injury nursing-based committee QI project. And I think I try to plug them in, let them have that aha moment themselves, like, we get to be a little physician-centric, I think, in our views, and I try to let it happen, and then let them realize, actually, this is more happening. Like the nurses are more active in this QI project than the physicians could and should be. Yeah. Great. Well, thank you for letting me share. I'm going to share a little bit more about the work that in my education work later, but this was really a joy. So thank you for everything.
Thank you so much, Dr. Euler. We're going to take a 12-minute break, and we are going to start on sharp at 1:15 with our platform presentation. For platform presenters, I see 2 of you readily, and I think the other 2 are here, so I've heard. Please make your way to the front, and we'll get you set up here. And if you need to take a break, now's a good time, but we're going to start at 1:15 sharp.
That's what I was just saying. That's great.
So there was some goes across QI.
All right. So like Dr. Reddy said, I'm Kevin O'Rourke. I am an emergency physician, and I'm the Director of Operations here at University Health. And so I just want to welcome everybody on behalf of the steering committee here today. This is the third year I've come to the QUIPS Research Day, and I love this day. This is my favorite days every year. It's just great to see everyone getting those stones out of their shoe. Those are my favorite kind of projects. Those are the things that bother me day in and day out. So without further ado, our first presentation today is Dr. Ahrens from Children's Mercy, who's going to talk about implementing balanced fluid resuscitation for sepsis patients in a tertiary care pediatric emergency department.
As he said, I'm Grace Ahrens. I'm a second-year emergency medicine fellow at Children's Mercy, and we'll be talking about balanced fluid resuscitation for sepsis patients today. I don't have any disclosures. So studies currently in adults show that unbalanced fluid and the use of normal saline compared to balanced fluid resuscitation can lead to increased kidney injury, need for dialysis, coagulopathy, increased systemic inflammation, and mortality in adults with sepsis. Small observationals in studies in children have shown similar outcomes. However, there has yet to been a large-scale study that has been published on this topic. The Society for Critical Care Medicine Surviving Sepsis Guidelines recommends many things to improve outcomes in sepsis-based mortality. Among these recommendations is balanced fluid resuscitation in pediatric patients presenting with sepsis. Lactated ringers, plasmolite, and albumin are all considered balanced fluids. Currently, normal saline is the most common fluid used in our sepsis resuscitation at the Children's Mercy Hospital Adele Hall Emergency Department at an overwhelming 95%. Currently, our sepsis process works as the patient walks in through the ED waiting room and gets put into triage. The electronic medical record sepsis screen helps identify patients with possible sepsis through the use of both vital signs as well as nursing assessment. It currently identifies about 80% of our sepsis patients. These patients are then brought back to an exam room if they have a positive screen, where a provider and a nurse will evaluate them in a more expedited fashion. Together, the staff are supposed to discuss and document a sepsis huddle to talk about goals of therapy for the patients. After the huddle, the orders are then placed and carried out. The aim of my project is to increase the percentage of patients with possible sepsis identified by positive sepsis trigger treated in the Children's Mercy Hospital Adele Hall ED receiving lactated ringers fluid resuscitation from 4.6% to 15% by June of 2024. Using PDSA quality improvement methodology, a multidisciplinary team including providers, nursing, human factors, pharmacy, and quality improvement was created. The team reviewed current processes and found several places, primarily through process mapping and fishbone diagram, where there was room to increase balanced fluid resuscitation. The fishbone diagram we used found several explanations why lactated ringers were not being utilized, such as access and stock of lactated ringers, education surrounding our ordering providers and our administrators, and sepsis tools and practices that are currently in place, to name a few. My primary outcome measure was the percentage of sepsis patients receiving a first fluid bolus as balanced fluid in the Adele Hall ED. The process measure that I focused on was our sepsis huddle form usage for those who trigger possible sepsis on the screen. One of our interventions focused around this huddle, and therefore we chose to monitor this as a process measure. We were unsure about changing the use of lactated ringers in sepsis and how it would affect other disease processes, so our balance measure focused on the number of times lactated ringers were ordered as a fluid bolus for any indication. Our first PDSA cycle started with general education for both the nursing staff and providers through our monthly division meeting. This was also emailed out to our staff as well. During this first cycle, our clinical sepsis pathway was also updated to align with current evidence-based medicine. Our sepsis order set that accompanies this pathway was updated to automatically check lactated ringers to encourage fluids to be balanced by our providers. Our second cycle in July of 2023 focused on increasing accessibility. Prior to this intervention, only 4 bags of lactated ringers were in our ED at any time. And so they are now stocked in a medication room in an overflow drawer to ensure easy access and availability for our nurses to start fluid resuscitation quickly. Our third cycle focused on adding a reminder to the sepsis huddle form to utilize balanced fluids surrounding a pre-existing question about fluid bolus administration. In February of 2024, through Gemba observations, we saw a significant increase in our float pool nurses that were being utilized in the ED. Given this, several nurses had not received any education about utilizing balanced fluid resuscitation. Education was distributed to the float pool nurses as our fourth cycle of our PDSA. Throughout the implementation of our PDSAs, a recurring theme of safety concerns over incompatibility with lactated ringers and ceftriaxone, our common antibiotic utilized for sepsis, was noted. If these get run simultaneously in the same line, there's a risk for embolization to the line, which can lead to adverse patient events. Currently, there's no automatic electronic checks for our compatibility to know that lactated ringers and ceftriaxone should not be run in the same line. It's currently our nurses' responsibility to input these medications into an internet program and check the compatibility or to have it memorized. There was concerns that there may be near-miss events where these could have been infused together. Due to this, a failure mode effective analysis was conducted in March of 2024 to help find areas where intervention could be introduced to prevent this mistake. During our FMEA, the process began with swim lane mapping about the path the patient takes from entering the emergency department to receiving lactated ringers. Subsequently, it was analyzed to determine possible places for failures or of recognizing the incompatibility. Major themes were then interpreted and places for possible improvement were identified. We found several areas that could lead to administration of ceftriaxone and lactated ringers, which you might have noticed by the amount of yellow on the other screen. If the orders are not placed at the same time, it's harder for our pharmacists to recognize and alert the provider that these should not be given together. Our sepsis huddle compliance has been fairly low, and it also has a variable amount of discussion that happens between our care team, which can lead to unclear prioritization for the team. There is no set system in our electronic medical record to help check incompatibility, and it requires the nurses to do this task manually. Providers are not commonly familiar with incompatibility. I was not prior to starting this project, and they may not know that they need to discuss which to prioritize first with their nurse if ordered together. There are often large care teams in our ED for the same patient, especially for sicker patients like our sepsis patients, and this may lead to assumptions that another nurse has checked our incompatibility or that there was a lack of communication about the discussion with the provider for administration priorities. Often we only have one peripheral IV access in children, as it can be traumatic to have more than one, or they can be difficult to get access on, and so this increases the likelihood that the medications will be run through the same IV. In addition, according to our current sepsis guidelines, it's recommended that both antibiotics and fluids get put in within the first hour, which leads to more pressure to run these medications simultaneously. Our most recent PDSA in April of 2024, resulting from the FMEA, had a communication that was ordered to our ceftriaxone order sentence to advise that it's incompatibility with lactated ringers in the same line. While our study is ongoing, we have some preliminary results. The amount of lactated ringers that are being used for our first bolus in sepsis patients in the ED have increased from 4.6 to 33.2%, which is a large centerline shift and has surpassed my goal. For my process measure, our sepsis huddle compliance has increased slightly from 45.6% to 51.83%. And for our balance measure, our amount of lactated ringer boluses ordered in the emergency department for any reason shows an increase from 32.9 boluses per month to 166.2 boluses per month. By using QI methodology, including traditional PDSA cycles as well as an FMEA, balanced fluid resuscitation was successfully and safely implemented in a tertiary care emergency department. My key takeaways have been that education is always key to any new process. Pre-checked orders in our order set proved for a high reliability intervention with sustainability. There was a culture shift in our patient population with lactated ringers being ordered for any patient, and Gemba was key to identify safety risks, system gaps, and educational gaps with staff. And discussing our limitations with our study, some of the data from process measures were built from a report that started in January 2023, so there was some limited baseline data. From our FMEA, we identified barriers but hit some institute safety measure issues to get kind of what we wanted to fix these across. So our institution policy right now relies that nurses check medication compatibility every time manually. The leadership had concerns that if we added an electronic pop-up or a nurse communication, that nurses would rely on this every time for other medications, so they did not want this. However, our GEMBA with human factors through observations in our ED showed that nurses do not check compatibility every time due to lack of time, and that they are not always checked prior to administration. And so this allowed for a compromise for our order sentence to be added into the ceftriaxone order that was associated with our sepsis order set. Our next steps will be to continue to work on interventions to increase safety with lactated ringers and ceftriaxone, and to determine other PDSAs to help increase lactated ringers to about 50% of all of our ED patients with possible sepsis. Our next PDSA cycle is hyperlinking our sepsis order set to the ED sepsis provider alert that pops up when you have a patient with possible sepsis, and that will be implemented later this month. So my references, and then I'd like to thank my team, my faculty mentors, Dr. Hushin, and then my quality improvement mentors, Chris Camberline, and they have been key to teaching me all the things that I didn't know, as well as Sarah Niehaus, Abad Siddiqui, Victoria Stoicheva, and Richard Simonson, which have helped with all the expertises of things that I don't know about our ED. And then my husband for watching our toddler and our newborn while I can finish up the presentation.
All right, thanks, Dr. Aarons. Does anybody have any questions from the audience?
I really love the balancing measure idea about like, is it going to increase lactated ringers in general? But I didn't get a sense like, is that okay? It did increase, right? So
Yes.
is that okay? Is that acceptable? Did you not want that to increase? Tell me more about the balancing measure.
For us, it's okay for it to increase. Really, we looked a lot into kind of our contraindications for our patient population, and apart from us, probably like our traumatic brain injury patients who we would desire higher sodiums for, as well as maybe some of our metabolic genetic kids, although there wasn't anything specific, I think, that we identified because lactated ringers has less sodium and then does have potassium, so it shouldn't be given to anybody who has hyperkalemia. But it increasing overall was okay. There really was no reason it wasn't utilized before. Other places do it, and it's safe. Just are creatures of habit in our ED, and so it was a lack of availability thing as well. So there has not been any increased issues apart from the incompatibility noticed with that increased imbalanced fluid.
You might have to give me grace because I do not work in pediatrics. But my question to you was there any consideration for a different first-line preferred antibiotic therapy? I think of in the adult population we have several different options we can use that maybe would have been compatible with LR to avoid this.
Yeah, we talked about it, and really everything else was kind of a step up of therapy. So for like our febrile neutropenic kids, they get cefepime and vancomycin, which is a little, for like our standard sepsis patient, is not typically what we would recommend. And so we had also discussed about doing ceftriaxone IM instead of through the IV, but you can imagine if kids don't like IVs, they really don't like IM shots, and their parents aren't huge fans of either. And so it was kind of settled that the goal was going to currently be to try to fix the safety surrounding this, because there are lots of things we could do. There are electronic medical checks that, could be added and things like that. We're just kind of working on changing that culture right now.
As a non-physician, I wanted to ask you a question. It seems from looking at your talk that one of the major interventions focused on the nursing staff. And I wondered, have you given this presentation to the nursing staff, and how easy is it for you to bring the changes that you wanted to bring about, to bring those to the nursing staff and to have them implemented?
Yeah, so I'm lucky enough that two of my nurses are actually here. We have a quality improvement nurse for the ED, and then we also have several nursing educators, and Sarah is my nursing educator that sat on my project, and so I've had really good luck through. I have talked to the nurses at a nursing meeting, they have like a quarterly distribution of information, and I've gotten on there. And then Sarah and Victoria have also been kind of key in helping implement this education, because obviously there's a lot of the nursing side of things that I don't know, incompatibility and all of those things. And so they've been really helpful in getting the nursing changes across.
All right. Thanks, Dr. Aarons. All right, next up we have Dr. Madan, a quality improvement initiative to increase osteoporosis screening in internal medicine resident-led primary care clinics.
Hello, everyone. Thank you so much for joining us today. I'm Ujjwal Madan. I'm a second-year internal medicine resident at UMKC, and I'm delighted to share our project, a quality improvement initiative to increase osteoporosis screening rates in internal medicine resident-led primary care clinics, which was held under the mentorship of Dr. Woolridge, Dr. Banderas, and Dr. Iftikhar. I do not have any disclosures to report. As we all know, osteoporosis is a disease that affects the most vulnerable population, our elderly. It causes an increased morbidity and mortality from osteoporotic fractures by causing limitation of ambulation, disabilities, chronic pain, and also subsequently increased mortality from that. Estimating the amount of disease burden, we know that almost 12 million adults are affected with osteoporosis based on the 2020 census. And the direct healthcare costs that are associated with the sequelae of osteoporosis have been estimated to surpass $25 billion by 2025. So if we look at the numbers, it's a huge number that we can impact with just a simple thing, prevention. USPSTF and our American Association of Clinical Endocrinology recommends universal screening for all women who are 65 years and elder using a bone mineral density testing, and most often central DEXA is used. We image the lower lumbar spine and the hips to look at the bone mineral density and diagnose osteoporosis and treat subsequently. The national osteoporosis screening rates vary a lot. So they are between 12% and 56%. Unfortunately, we found a practice gap in our resident-led primary care clinics, where pre-intervention, this rate was lower than the national average at 4.8%. So to address this practice gap, we came up with this idea for our QI initiative. And our aim was to increase osteoporosis screening rates using a DEXA scan among the eligible patients, our 65 years and older women, patients who were seen in resident clinics at UHTMC and UH Linwood clinics by 25% in 3 months by January 2024. And this was aimed to be done through the implementation of EMR modification, resident education, and clinic reminders. We included any female patient who was 65 years or older who received care at UHTMC or UH Linwood, whose PCP was a resident, an internal medicine resident. Our pre-intervention period was July 2023 to November 2023, and that's when we implemented our intervention from November 2023 to January 2024, and then we subsequently had our post-intervention period. Our interventions were sustained and non-sustained. So our sustained intervention was an EMR modification. Prior to our project, there were some discrepancies in our Cerner database showing a constant pop-up for all eligible patients who required a DEXA scan based on their eligibility criteria. So we sat down with our Cerner IT department and worked through this, and now it consistently reflects the DEXA scan order as a pop-up in the health maintenance tab. For those patients who've had a prior DEXA, which was completed in the past, it also shows up at the bottom of the health maintenance tab. We educated our residents about this EMR modification. The second half of our intervention was non-sustained, and this was resident education through educational lectures, primarily our noon conferences. We also had infographics, posters, patient handouts, which were put up all throughout our clinics. And we had social media posts being run through our resident Telegram groups. And then lastly, there were clinic reminder stickers, which were placed on all the computer screens for our primary care clinics. We measured the number of DEXA scans ordered by all our residents in all the eligible patients, and this was analyzed as a proportion of the DEXA scan orders placed among all the eligible patients. We did not measure the amount of DEXA scans which were completed, since the aim of our project was only to improve osteoporosis screening rates by an increase in the number of orders being placed. This data we tracked with the help of run charts for monthly DEXA scan order rates. The second half of our results included resident knowledge assessment with the help of anonymized online REDCap surveys, which were administered pre-intervention somewhere around October, since our intervention was coming up in November. And then November through January, we had the resident education being done. And subsequent to that, we administered our post-intervention surveys through REDCap. So we did not have a balancing measure, and our process measure was the number of DEXA scans ordered. Looking at the results, as I mentioned before, the rate of DEXA scan orders prior to our intervention was 4.8%, but this jumped to 12% post-intervention. While we did not achieve our aim, we definitely saw a 60% relative increase. If we look at the number of DEXA scan orders as a percentage in the form of our run charts, with the blue line tracking the percentage, you can see that in August and September, our rates were somewhere about 12%, which fell to about 2%, and then it dropped to 0. And this was a huge discrepancy as compared to what the national averages run. As soon as we implemented our intervention in November, the numbers improved to 15%, which almost stayed there through January. And as soon as we took back our resident education part, it fell back again to 5%. And therein comes in the importance of subsequent PDSA cycles to actually improve this to a national average and maybe even do better than that by actually sustaining the effects of our QI project. Looking at the resident knowledge part of things, we had about 61.9% residents report that they sometimes ordered a DEXA scan. This improved to 30% who ordered it sometimes, 32% who often ordered it, and 8% always ordered a DEXA scan post our intervention. The numbers in terms of the knowledge was fairly okay. 91% were already aware of screening modalities and treatment options prior to our intervention, and this number improved to 96% subsequently. 54.5, which is about half of our residents, were comfortable to screen and treat for osteoporosis prior to our intervention, and this number improved drastically to 87.8% residents feeling comfortable treating for osteoporosis in patients that they saw as PCPs. Interestingly, we also had residents report the barriers that they felt for ordering a DEXA scan, and clinic visit time constraints and uncertainty about patient preferences were the most commonly reported barriers to this. Meanwhile, the most commonly reported barrier for a completion of DEXA scan, which was reported by our residents, was found to be just patient non-adherence. To summarize, I would like to reiterate that the national guidelines recommend screening for osteoporosis in all women who are 65 years and older using a central DEXA scan. And we can see with the help of our project that we included female patients in this age bracket and performed interventions in the form of EMR modifications and resident education, which led to a 60% relative improvement in DEXA scan order rates. It also led to an improvement in our residents' knowledge of screening criteria and treatment options for osteoporosis. To conclude, there was an increase in the rate of DEXA scan orders in the resident clinics at UHTMC and UH Linwood in the 3 months of our implementation of EMR modification, resident education, and clinic reminders. And we can basically bring evidence-based medicine in our practice by incorporating the national guidelines through a simple trick that is resident education. And we can lead to a huge improvement. And if you look at it on a national scale, there's a long way to go in terms of improving screening rates for osteoporosis. These are my references. And I would like to thank our mentors, Dr. Woolridge, Dr. Banderas, and Dr. Iftikhar, who supported our project, our Cerner IT department and UMKC IT department for helping us gather this data. And of course, our internal medicine residents who we pestered for completing our surveys and who were diligently involved in improving osteoporosis screening all through the project. Thank you so much for patiently listening.
Thank you, Dr. Madan. Any questions?
Great job. This is Raj Bhattacharya, endocrine. Two quick questions. One is, in Linwood Clinic, is there a bone density machine?
That's a great question. So for UH Linwood, basically for both UH-TMC, where UH2 is the primary care clinic, and UH Linwood, we were basically tracking the order rates. And then subsequently in the patient handouts, we were telling the patients to get it done at UH-TMC on the second floor.
Okay. So there's not, there's no bone density machine?
Yeah, no bone
So
density.
that could be a great implementation to simply have one in clinic. Not in clinic, but close to the clinic. The second important question is, once you graduate, can you pass the baton to anyone else? Because that would be incredibly important to continue the education and aspects like that.
Thank you so much for bringing that up, Dr. Bhattacharya. I already feel like the first year residents who were part of the project, they're motivated, and I would be happy to give the baton to them going forward.
Yeah, just to kind of echo on those sentiments, this is a wonderful topic, and it's a national issue, and a lot of us in this room are kind of familiar with it, so thank you for taking this on. A lot of people have tried. Some of the things that have come about in talking to other organizations, like in Georgetown and DC, what they actually implemented was a way to detect patients who have osteoporosis off of CT scans, and then they will trigger a recommendation to get the DEXA scan. Now, again, that requires some different ways of thinking, and you probably want to engage a different team on it, but it sounds like you guys are looking to build a whole practice around osteoporosis. So this would be one way to do it and really drive that and not have the capital cost of a potential machine and all that stuff. So there are many awesome things that we're seeing around this space, but as you pointed out, this is a big national issue. So thank you for addressing it.
Thank you so much for bringing that up. I feel like that might be actually an idea to implement in our subsequent second PDSA cycle of going for this project.
Wonderful talk. Were you able to include a cost-effectiveness study of, how many what was the increased percent in patients that actually had osteoporosis upon the increased screening? And of those that had osteoporosis, what stage was it? An early stage where you could treat early? Were you able to look at those numbers?
Unfortunately, as part of our project, we were only tracking the number of DEXA orders placed. So we were not able to look at the number of DEXA orders which were completed and thereby received treatment for osteoporosis. But I do know that there's a study that I went through on a national level which was published. It mentioned that of almost the females who had a hip fracture, almost about 20% were the only ones who had had a prior DEXA screening in the preceding 2 years. And out of that, only astonishingly about 10% ended up receiving treatment for osteoporosis. So I would estimate that the same numbers would apply to our population as well, but we did not look into the exact numbers of DEXA completion rates.
Thanks, Dr. Madan.
Thank you so much.
All right, thanks again to our members of our resident and fellow section. And now we're going to move on to our students
who have been chosen as the top abstracts in the student category. Our first student is Kayla Rifle, and she's going to talk to us about improving detection of chronic kidney disease in adults at an academic outpatient primary care clinic. Thanks, Kayla.
Hi everyone, my name's Kayla. I'm a graduating medical student here, and my project is improving detection of chronic kidney disease in adults at an academic outpatient primary care clinic. We have no disclosures. So I just want to give a quick introduction about CKD and why our project is important. So chronic kidney disease, or CKD, impacts millions of people in the United States. It carries significant morbidity and mortality, increased healthcare costs, and is often under-recognized by physicians and patients. In fact, up to 90% of patients with lab evidence of CKD are unaware of their diagnosis. CKD disproportionately affects patients with a lower socioeconomic status, and these patients often have more limited access to treatment and worse outcomes compared to patients of a higher socioeconomic status. Unlike other chronic diseases like diabetes and hyperlipidemia, there are no universally adopted screening strategies and little to no quality measures or incentives that promote or prioritize CKD care. Prevalence of CKD in the US is estimated to be over 14%, and in our project we use prevalence as a surrogate marker for detection rate of CKD. So when we're determining our baseline prevalence at our institution from fiscal year 2021, we discovered that our prevalence was 1.9%, revealing an alarming gap in the detection rate at our clinic. So our aim of our project was to increase the prevalence or detection rate of CKD from 1.9% to greater than 6% by March 1st. So our project was deemed non-human subject research by the IRB. It was conducted at a family medicine resident clinic in the Lakewood campus. To determine our baseline prevalence, we did a retrospective analysis of EMR data from fiscal year 2021 and got the 1.9%. We included any patient 18 years or older seen by any physician in the clinic. After we had our baseline prevalence, we performed a root cause analysis using a fishbone diagram and discovered that the three main contributing factors to this low prevalence was physician awareness and education, a lack of standardized process in clinic, and then difficulty navigating the EMR and finding the diagnosis there. We also used a pick chart to help us organize our ideas and develop countermeasures. It included a lot of resident education, making a standardized process, and manual review of the EMR. So our project so far has had 7 PDSA cycles, and I'm actually going to go to the next slide just so you can follow along easier with the timeline. Our first intervention was just establishing a relationship with the National Kidney Foundation with the hopes to brainstorm ideas for interventions for this project. After that, our next intervention was a resident-led lecture about CKD management and implementation of a dot phrase in the EMR. And here's the dot phrase. So the hope with that was to make it easier for residents to know what to look for when they're managing a patient with CKD. After that, the next intervention again was resident education in the form of didactics. It was a lecture about CKD management given by family medicine physicians and nephrologists, and then also changing the EMR and adding a kidney order set, or a kidney profile order set, which included a GFR and a urine albumin creatinine ratio. After that, we established monthly meetings with the National Kidney Foundation. So that includes them and anyone from the clinic who wanted to join. We discussed challenges of previous interventions and brainstorm ideas for future interventions with them. After that, again, resident education in the form of grand rounds during orientation for the new interns. Our next intervention was changing the EMR again and adding a dashboard that had all of the quality metrics needed to monitor someone with CKD, including blood pressure and kidney labs. And then finally, our last intervention has been a retrospective analysis of missed patients. So for this intervention, we compiled a list of every patient with a GFR less than 60 who was seen at the clinic between November of 2022 and November of 2023. We created a Pareto diagram to figure out the most contributing causes to the potential misdiagnosis in these patients. So the largest column on the left represents patients who had a GFR less than 60 that showed as normal in the EMR. So even though they had other lab evidence of CKD, their diagnosis was missed just because the GFR appeared normal in the EMR system. And then the second column represents patients who had lab evidence of CKD, but the diagnosis was missed because their confirming labs were done outside of the clinic, like in the ED or a point of care lab, and it did not result back to the clinic. So the diagnosis was missed that way. So this intervention is helpful because it gave better insight on the most contributing factors and will help us tailor future PDSA cycles. And for our results, as you can see on the run chart here, our prevalence or detection rate at our clinic increased from 1.9% to 10% over the course of the project so far. We have several trends in our run chart indicating a statistically significant increase in the detection rate at our institution. So to summarize here, despite the high morbidity and mortality of untreated CKD, baseline data indicated a large gap in the diagnosis rate of CKD at our clinic. Our institution primarily serves the safety net patient population, so it's important to address this issue with our patients. Our project was successful in increasing the diagnosis rate of CKD, and we achieved this using a multifaceted approach targeting resident awareness, EMR, ease of use, and creating a standardized process in the clinic. An unintended consequence includes increased costs from hiring nurse care managers, which I'm not sure if I mentioned before, but the nurse care managers were the ones who did all of the retrospective review for the last intervention. So awareness surrounding CKD and prompt diagnosis and treatment is imperative in creating high-quality, equitable healthcare. Our QI project highlights the importance of resident education, easy-to-use EMR systems, and implementing a standard practice even when universal screening guidelines don't exist. A limitation from our study is the data are from a single family medicine clinic, and it doesn't include data from the internal medicine primary care clinics or the family medicine clinics at Hospital Hill. So adding those in may alter the prevalence a little bit. In the future, we hope to implement an EMR diagnostic tool that automatically tracks CKD labs and alerts physicians of the new diagnosis, but unfortunately, this is a very costly intervention and it's dependent on funding in the future. As part of our sustainment plan, we plan to continue integrating review of missed patients into the nurse care manager workflow. We are going to do continued resident education during orientation and throughout the year through didactics and grand rounds. And then we also plan to do monthly reviews of physician quality metric reports, and that includes the CKD incidence for that month and lab monitoring of patients who are diagnosed with CKD who are automatically enrolled into the quality database. Here's my references. I would like to thank the QUIP Scholars Program and the Rayudu Family and Friends Endowment for support on this project. I would also like to thank all the stakeholders, Dr. Gray for being a wonderful mentor, the clinic support staff, and the nurse care managers for all of the work that they do.
All right, good job, Kayla. 7 PDSA cycles in less than a year is pretty impressive for anybody.
First of all, I think this is a really amazing project because not only are you impacting them on the ambulatory side, but this has a huge impact from an inpatient perspective. And even as patients get listed, maybe in the future for transplant, etc. So kudos to you. I do have a question because one of the things that you talked about is that clinic is a safety net. Did you take into any consideration of looking at maybe patient demographics, especially for your misdiagnoses based on like healthcare equity in any capacity?
We have definitely considered that. We did keep that data in case we want to do a different project kind of related to that. But it's definitely important, and I think it has a big impact on that as well.
Such a great project, and I had two questions. One was in the graph. I noticed that there was like a significant dip in July and August. I think many people noticed that. Yeah. And, you know, academic medicine, we know July and August are tough times. There's lots of new doctors. You know, you don't want to come to the hospital in July. But and then I noticed that in your sustainability plan, you had that orientation as when you were going. And I was wondering about the choice of orientation and are there other places? I orient a lot of new interns every year, and I just feel like it's like turning a fire hose on. Do you know what I mean? And I sometimes worry that they miss things in orientation, and then things that are given like a month or 2 months later when they've had some experience. So I was just wondering if you could talk about your thinking about when to place that like annual education around CKD.
Yeah, great point. So to explain the dip, we think it's a combination of the new interns coming in, as well as because they're new, there's less clinics scheduled and less patients being seen. So that might also contribute to the low prevalence, but definitely shows the importance of resident awareness and education in diagnosing CKD. As far as the education part of it, I think we plan to do scattered education throughout the year, because I do agree, like, I'm about to be an intern, and I'm sure that a lot of things that people tell me will just go right over my head at first. So in addition to orientation, I think that we all plan to do like didactics throughout the year or a grand round lecture, kind of like we've been doing.
All right, great. Thanks, Kayla. Last but certainly not least, Dr. Priya Patel, future almost doctor, decreasing blood culture contamination rates in the emergency department at Mosaic Life Care St. Joe.
So hello everybody, thank you for being here to listen to our project today. The title of our project was Decreasing Blood Culture Contamination Rates in the Emergency Department at Mosaic Life Care in St. Joe. I am currently a fourth year student at the UMKC St. Joe program. And then we have members of our QI team listed on this slide, many of whom are here today, so that's very encouraging to see. So I'm going to start by, there were no disclosures or conflicts of interest. This project was considered non-human subjects research as designated by the Mosaic Life Care IRB. So a little bit of intro. I initially came about this problem when I was doing my infectious disease elective rotation back around the summer of 23. And during this rotation, my attending actually took me to an infectious disease management committee where I learned about some of the issues that the hospital was facing. And this was one that they were talking about for the last several months. And through this meeting, I learned that some of the culture contamination rates were well above 4%. And then the national benchmark is 3%, and that percent is set by the American Society of Microbiology and also the Clinical Lab Standards Institute. So it's basically like a benchmark that all hospital systems in the country should be following. So why is this important? Contaminations can comprise the quality of care and contribute to negative patient outcomes. And then I have some of those listed here, which can lead to like unnecessary antibiotic exposure, antibiotic resistance, prolonged hospital stays, delayed treatment plans, as well as increased costs. Through some of the research that we have done, we realized that some of the costs could range anywhere from $5,000 to $10,000 in additional costs for one contamination. So then we created our AIM statement, and our project aim was to decrease blood culture contamination rates in samples obtained from our ED from the initial 4.3% to 3% by March 1st of 2024. So next I'm going to talk about some of the QI tools that we used for our project. We initially started having meetings with some of the leadership involved. So we met with the lab, we met with infectious disease department, the emergency department, and we did a lot of site visits just to kind of learn about where our system was at right now, if a lot of the people knew that this problem existed, and what kinds of things have been tried in the past. So we kind of created a process flow map, again, by talking to all of our stakeholders, but also looking at the hospital standards on how these are supposed to be drawn. And then we created a simple flow map, and then some of the orange boxes we have listed are some of the possible deviations that we thought these contaminations could be coming from. And then I'm gonna go, so then we created a fishbone diagram, again, taking into consideration all of our stakeholders' opinions, and then we decided to focus on the collection aspect of this. A lot of the stakeholders had mentioned that they thought this was a cause of the root problem. So we have some of the things that we considered, and then we have it circled on that box. And then from that, we created a Pareto analysis, and that was to look at some of the most frequent things that could be contributing to these contaminations. And then again, the highest thing that we noticed was that protocol deviation. So a lot of the caregivers might be missing steps or doing steps a little bit off from what the standard was. And then from that, we created a pick chart. So then what we wanted to do was pick something with a high reliability level, but also had an easy, like something that we could easily implement. So we have 3 of our interventions that we have labeled. So we started off with an initial campaign awareness, followed by some contamination warning flyers that we used, and then we finished out with a new hire handout. And then we also had some different implementations that we have listed on there. So our first countermeasure was implemented back in October 1st of 2023. And like I mentioned, that was our initial awareness campaign. And this was implemented following all of our initial site visits that we did. So our main goal for this was to bring awareness to the problem to all the caregivers and the people that were directly involved in this whole process, and kind of to educate the staff. One thing we learned was a lot of the caregivers and people in charge of drawing these cultures just weren't aware that this was an issue. So that was like where a lot of our brainstorming for the first countermeasure came from. So we kind of just talked to them about how these rates were high, what that can lead to, and kind of just talked to them about why they thought this could be a thing that was happening, just to kind of get that feedback. In terms of countermeasure 2, so following that, we implemented this around the end of November of 2023. So on the left, we have what we call badge buddies, or badge reference cards that caregivers could stick on their badge holders and have to reference them quickly. And then on the right, we have like a big flyer, and these were placed strategically around the ED. So our ED had 2 stock rooms where you would have to go to get these culture kits in order to draw those blood cultures. So we placed them on both of those stock rooms, as well as placed them at the nurses' station. For countermeasure 3, and this was implemented on March 1st of this year, and this is basically a tip sheet that is placed in new orientation hire packets. It had a similar tips on there. We added a couple different things because the protocol for drawing these cultures was changed here recently for our hospital. So we kind of just wanted to make sure everybody was on the same page and that they were aware of these new changes. And then for the results, we gathered data about every month. So we worked very closely with the lab services at our hospital. And anywhere from 1,200 to 1,300 cultures are typically drawn from the ED in a month, and usually the contaminations can range anywhere from the high 30s to low 40s, and that was pretty much the average. So, and then after all of that, we created a run chart, and we have all of the things labeled with all of the dates. Following countermeasure 1, our rates decreased from 4.42 to 3.5. And then we actually did meet our goal of getting under that 3%. Our rates following countermeasure 2 actually went down to 2.9%. And then following countermeasure 3, we saw a little bit of increase in that rate to 3.1. And then our most recent one was March of 24, which we saw that rate go back to 3.5%. So we kind of went back to leadership and kind of asked them why this could have been a thing. And we had a lot of feedback in terms of the amount of cultures had increased. So in that month, there was a lot of cases of influenza and COVID. So there was a lot of extra cultures that were being ordered. And I think the average was about 1,500 for that. And so in summary, the countermeasures were successful. We had overall positive feedback from the leadership and caregivers. We made sure to go back following everything we did just to make sure everything was going smoothly. We received very good feedback in terms of how the signs were very catchy. A lot of the caregivers began to understand why this was an issue and why it was important. And then in conclusion, the blood culture rates in the ED declined significantly through increasing staff awareness and displaying informational signage in strategic locations to promote adherence to proper blood draw techniques. And then talking about future aims, we understand that sometimes educational interventions may not be the most sustainable, and we kind of talked a lot about that. Our hospital system actually back in 2009 actually did like a similar educational intervention. So we kind of talked a lot about that, and we thought in order to sustain this, we would need like a student-led focus on this. So we actually have recruited some junior members that are currently helping us as well. Yeah, so the current methods have been working. We are still talking about some of the ways we can implement more countermeasures. One of the things we've talked about is using like single-use diversion devices, but also kind of looking at some of the things like night versus day shift to see if there's any differences between that as well. And then we've had a lot of investment from the ID and ED departments at our hospital. So there's a lot of individuals involved that are wanting to make change happen and hopefully sustain this. And then those are our references. And then credits and acknowledgements. So this project was made possible by the Equip Scholars Program. And we would like to thank the Mosaic Life Care Emergency Department, Infectious Disease Management Committee, and the Department of Infectious Disease for partnering us with this project. And then also Dr. Reddy and Sari for the opportunity to participate. And then Dr. Spears served as faculty member for this project.
Thank you, Priya. Any questions? I'm gonna come stand next to you.
Thank you. A great talk, very interesting project. So when you were speaking to the staff members that draw the blood, did you gain anything from their insight into what you think was the most important contributor? Was it, a complete lack of understanding of technique, or was it more number of patients that they were more concerned about? Was it more they felt overwhelmed, they had so many patients that, sometimes?
Yeah, that's a good question. I think it's a little bit of both. The ED, we also compared like how many cultures were drawn from each department, and the ED surpassed all of the other departments in the hospital by far. It had the most every month. But from talking with all the caregivers, we realized some of them, even ones that had been working at their job for several years, just weren't sure that they were missing a step that they were supposed to do. So a lot of the feedback we got were from reading the signs are like, oh, I didn't even know I was not doing this when I was supposed to be doing it. But also to your point, I think it is just like the sheer volume of patients that they get, and then the fast-paced environment.
So in the ED, I understand why there would be an increased volume. Again, I'm not a physician. Was there ever any thought about looking at if the ED was prescribing more culture, more culture screens than necessary, or was there a way to reduce that, maybe for patients that it wasn't really necessary for?
Yes, so that was actually also another topic that we talked about, more of that diagnostic stewardship and how many are actually being ordered versus how many should be ordered. At that time, we were mostly focused on awareness more, but that's definitely something that we're looking more towards as we go on, is more of that diagnostic stewardship. Mm-hmm.
Another thing I thought about, I'm a big fan of sticks instead of carrots, and giving pointed feedback to the people. Maybe there's certain nurses who are contaminating, right? Like you have surgical site infections, looking at like the surgeon, and maybe looking at nurses who might be contaminating more than others.
Yeah.
Priya, thank you. Really excellent project. I have a comment and then maybe a question. So the topic of blood culture contamination rates is a really large topic, and it would generally be something we might discourage a student from taking on because it's so giant and maybe not in your realm of influence. So I think you just showed us that that's not really true, that you can take on any project you want and scope it to something that you can manage. And you minimize the effect of education, which we say that because of the high reliability of education long term. But I think you took on exactly the part of the project you could take on as a student. So really nice work with that. And I'm also recalling how Dr. Euler was just talking about connecting what a student wants to do, what you're inspired by, to something that matters to the institution in terms of institutional goals. And that's probably why it's a big topic. So my question for you is, I mean, you mentioned leadership buy-in at the emergency department level, and you had mentorship from infectious disease. But what kind of interest has there been from the very senior level of leadership at the hospital on a topic that matters to the institution?
They've also been very supportive of this. When we initially brought this up, they were talking about how they have been looking at this problem for the past several months. So when we brought that idea, like, could this be like a student-led project, they were very excited. So we began meeting with them on a regular basis just to make sure we're not overstepping, making or causing more harm than good. So that was very big, but they've been super invested. We stay in touch like periodically, at least once a month, if not more, just to make sure everything's going okay. Yeah, and overall just positive feedback from all the leadership.
All right, thank you.
Right. Excellent. Thank you very much. We're not going to take a break. We're going to go right into our awards and recognition because I want this to be done out of here at 2:30. As I'm thinking about these platform presentations, I'm really in awe because often, when QI people talk to research scientists, we're kind of told that it's a softer science and it doesn't have the rigor, and yeah, it's publication worthy, but it's not as important. But I think these 4 projects alone, forget the projects we saw all morning, show us that we all have a part in improving the system in our own way, in our small ways, and that's actually how we make the biggest difference. So thank you for showing us that and for sharing your work. I have a hefty agenda I want to go through here in the next 15 minutes. I want to review the highlights of the poster showcase that features the abstracts that were submitted in both categories throughout the morning. And of course, we're all waiting to hear the QUIPS poster competition winners from the morning. I want to recognize those winners and also faculty judges who make this possible. And then I want to introduce you to graduating QUIPS scholars and also the rising cohort of QUIPS scholars that begin next week. And then we have the QUIPS Faculty Mentor of the Year Award. Then we'll close with some final reflections from the Rayudu family. So this forum invites abstract submissions from teams that conduct projects that address all kinds of system issues affecting healthcare quality and safety. Projects that we receive typically fall into 2 categories: safety and quality. We say quality as another category. Safety projects aim to eliminate, prevent, reduce, or mitigate injury and harm, while quality projects seek to improve something in the system, whether that's effectiveness, efficiency, equity, patient-centeredness, or harmful delays and wait times. So these action-oriented words delineate the difference between the intent in a QI effort and a research effort. So something that we like to really promote is the difference between QI and research. All QUIPS projects, whether they're quality improvement or patient safety projects, utilize improvement methodology or patient safety science to implement and evaluate innovative and evidence-based change ideas. And so with that, we have created this abstract scoring rubric that's a little different than a scientific research forum, because the goal of this forum is to elevate those efforts that hold those key elements of a QI project, such as projects that clearly state the problem as a numeric gap, where we are and where we need to be, that implement at least 2 experiments to close that gap. And we want to see data displayed prospectively in time series to show the spirit of continuous improvement. So this year, we had 47 submissions involving 241 individual contributors from 11 academic departments. That's phenomenal. So since this program was established in 2014, we've kind of kept track of the number of student projects and resident and fellow projects that are submitted each year. And while we always love to see this volume of projects submitted, really what I'm most impressed by this year compared to even the last several years is that the increase in the number of projects that introduce at least one intervention aimed at improving an institution-specific process, problem, or program. So that prospective nature. And let me tell you what I mean by that. So this year, of the 47 projects that were submitted, we had about 13 projects that followed a pretty common research design. We had 14 projects that had a prospective design, and we had 20 projects that actually included a gap being closed with 2 or more experiments with data shown over time. I'm just trying to find the perfect word, amazed at that outcome right there. Now, as I preach about how you show data using bar graphs as opposed to continuously showing the improvement, I also want to show you this. And this is something that probably only advisory committee members have seen from us because it's kind of the behind the scenes mission for what we would want a QI program to have in the very long term, 5 years, 10 years. So we focused on specifically student-led projects because that's where our impact is with curriculum. We have wonderful resident-driven programs and resident education, but our focus was on students that we could take wider. Our goal was to see that all student-led QI projects submitted to QUIPS Day would introduce at least one intervention aimed at improving an outcome. And when we started the program early on, there were only 9 student projects even submitted. And of those, we saw, kind of hitting the line here. And in 2020, we began some very specific interventions to move this target. And I just want to show you what's happened here. So we kind of just put this together yesterday as we were looking at scores and finalizing our judging system. And when we saw that, it's not quite wrapped up yet, but when we saw that, we just knew we had to share that with you. So congratulations to the 4 platform presenters. Phenomenal job, and you're actually setting the bar really high for those of the others in the room who know they're going to be doing this next year. So I always like to point out the action-oriented words and just the titles alone. And I want to, sorry, can you help me show us how we can look at the poster showcase? Because if you were in a room watching section A or section B, you wouldn't have had a chance to see the other posters. And so there's an opportunity to do that through the virtual poster section.
Yeah, so this video I made that will kind of play in the background here, I made this a few years ago during COVID when everything was actually video presentations online. We've since changed them to just the posters. But if you search by the name of our event on Google, you will find this, and you'll find every single poster that was presented this morning. You can click on any poster and it'll pop up as a PDF for you to look at. So everything that was shared today is available to you now on our website. And so if there's a topic you want to learn more about, you were in one of the rooms but not another, all of that's there, including years past too. So we've got now, probably not 500, 490. Yeah, 491 projects. I think the early years are not linked on the website, but they're listed. I know at least since 2020, our projects are in there. So,
thank you. Sorry. So if you were an oral presenter this afternoon, or if you presented a poster this morning, you may claim credit publicly for your work on your CV by citing your abstract using the following format. And we'll share this with you by email afterwards, so you don't have to take a photo of this. Right. Next, I'm pleased to invite Malika Joshi to join me in announcing this year's poster presentation winners in the student abstract category. For those of you who may not know Malika, she earned top honors as a platform presenter at the 2023 QUIPS Day event and also the 2021 QUIPS Day event when she was a younger Year 3 medical student. Malika completed Cohort 1 of the QUIPS Student Scholar Program and will be graduating next week with a commendation titled Distinction in Healthcare Quality and Patient Safety.
thank you.
So
It is an amazing honor to be here, and I get to congratulate Natalie Meyer and Satya Shivashankar on this award. You guys can come up here if your mentors are ready. Okay.
How about you just stand?
Natalie's team presented a project titled Decreasing the Use of Violent Physical Restraint in a Tertiary Pediatric Healthcare System. And Satya's team presented a project titled Decreasing Inappropriate Stress Ulcer Prophylaxis in the Surgical ICU. So congratulations to you both, congratulations to your mentors and your project collaborators on this honor.
Thank you, Malika. Next, I'm pleased to invite Brittany Eichenauer to help me present the poster presentation winner in the resident and fellow category. Brittany is the Director of Quality and Safety at St. Luke's Hospital, Kansas City, and she's a member of the QUIP Steering Committee. Brittany's expert insights and guidance help us steer the day-to-day activities of the consortium. We're grateful to St. Luke's for allowing us the opportunity to work with Brittany on these initiatives that add value to our shared academic goals.
Thank you. All right, I get a really fun task. So for the poster presentation winner, resident or fellow category, I am pleased to congratulate Dr. Saker Alsakarne and Dr. Mitchell Kinker.
Are you both here?
Might be in the virtual. So hopefully you all can hear us. Congratulations.
Yeah. So Dr. Alsakarne's team presented a project titled Reducing Inappropriate Use of Proton Pump Inhibitors in Outpatient Settings, a quality improvement project. And Dr. Kinker's team presented a project titled More of Less, Optimizing Opioid Prescriptions for Acute Fractures in the Emergency Department at a Children's Hospital. Congratulations to both of you, your project mentors, and your project collaborators for this honor.
So the 4 poster presentation winners, as well as the 4 platform presentation winners, are eligible for a travel award for one author to travel to a conference to present this regionally or nationally. And so we'll talk to you more about how you can claim that prize over the next months. So we have to thank our faculty volunteers who scored abstracts. It's a small army of 27 engaged faculty who reviewed abstracts for us in what we call round 1. And that means that each abstract was reviewed by at least 3 judges. And this serves 2 purposes. Not only does it give us the opportunity to host this forum, but it also helps faculty to have the exposure to QI methodology simply by looking at a QI scoring rubric. So thank you to our first round judges. And then we had a smaller group of what we call second round judges that determine from the top 10 who will be our platform presenters. Just a smaller group for us to manage, so thank you to all of you. And then thank you to our poster session judges. We had 5 concurrent sessions this morning with 8 or 9 presentations in each room with a panel of 3 judges in each room. That's a lot of coordination, and it actually went off without a hitch. Absolutely not even one hitch. One tiny one. But it was very easily resolved. All right, so next I'd like to introduce you to the rising cohort of QUIP's faculty scholars. Will you all please stand? Please stay standing. So these 8 faculty have actually been working hard already, even though the program doesn't officially launch until next week. It's been several months of many project ideas and some ideas that didn't work out, but very quick recovery on designing a new project charter. So it's been really impressive to watch these guys do that work in these last several months. Please stay standing as I introduce you to the incoming cohort of QUIP student scholars. Please stand. Sorry, and I've met with you all once or twice, so I actually would not recognize some of you on the street yet. So more next week, and we have more work to do. So you know what you're working towards from today's forum. Thank you. Next, I'd like to congratulate the graduating QUIPS faculty scholars. If you could all please stand. And please stay standing as we ask the graduating QUIPS student scholars to please stand. As the evidence that you saw this morning in our poster sessions, so many judges coming out and saying these are just amazing projects that have QI methodology with the rigor that we like to see. And these are QI specialists who do this as a part of their everyday work. So thank you very much for a really, really, really wonderful year. You guys have done outstanding work that surpassed my expectations. Thank you. So next, I want to congratulate the 5 graduating students, Kayla in this cohort and also others from last year's cohort, Lena and Kayla. Would you like to come say some words? So these graduates will be awarded the QUIPS Commendation titled Distinction in Healthcare Quality and Patient Safety at the hooding ceremony next Friday. I'm so proud of your projects that explore scientific stories. Each of you were able to experience something that I wasn't expecting, so I'm really, really impressed and proud. It's been a pleasure to work with each of you as I watched you exercise your brilliant problem-solving skills. Best of luck to you as you embark on your next adventures as QUIPS leaders, leading the charge to sustain today's healthcare system for tomorrow. Let you say yours.
So my name is Lena.
My name's Kayla.
I'll tell you about experience working with our QUIPS faculty scholars. My faculty scholar, working with her has been a transformative experience. My mentor fostered an environment where curiosity and questioning were encouraged, teaching me to look beyond conventional approaches to solving problems. This mentorship has been a cornerstone for my developmental understanding of improvement science, equipping me with confidence and excitement to continue the mission of improving the future of healthcare.
For me, working with a skilled faculty mentor has expanded my understanding of QUIPS methodology, interprofessional communication, problem-solving skills, and critical thinking. Collaboration with my mentor on this project provided me with invaluable hands-on experience and has deepened my passion and lifelong commitment to improving healthcare processes throughout my future career. My mentor is a compassionate, supportive, and dedicated person both personally and professionally, and is very deserving of the QUIPS Faculty Mentor of the Year Award.
So it's my honor to present this year's QUIPS Faculty Mentor of the Year, but this year I am pleased to recognize 2 very special faculty. As mentors in the first cohort of the QUIPS Faculty Scholars Program who continued on with the second cohort, these individuals have supported the consortium's journey to build a QUIPS student mentoring program, living the mindset of experimentation not only in the technical design of their QI projects, but also in the mechanics of their coaching acumen. They've demonstrated outstanding leadership in creating invaluable scholarly experiences for students during their voluntary administrative time while balancing full clinical workloads. For their exemplary commitment to mentorship, modeling QUIPS leadership to the future leaders of tomorrow's healthcare system, it's my honor to present this year's QUIPS Faculty Mentor of the Year Award to both Dr. Alicia Daggett and Dr. Kevin Gray. Dr. Daggett. If you would please stand. Thank you. All right, so anyone who I asked to stand, including the 4 presenters and the 4 poster presentation winners, if you'd please stay after for just a few minutes so we can get some photos. But I'm going to close with another program that has been modeled off of the QUIP Scholars Program. It's the Mindfulness in Medicine program. The definition of mindfulness is the awareness that arises by paying attention on purpose in the present moment. This program is also a longitudinal practice-focused program with a cohort of 5 to 15 medical students and 5 to 8 faculty with subject matter excellence and wellness practices. And this also culminates in a commendation titled Distinction in Mindfulness in Medicine upon graduation. And here is that lovely cohort. And the reason I'm showing you this is the connection between mindfulness and patient safety is so clear. And just this week, I heard a presentation from a rising QUIP student scholar, Lauren, on Kaizen and mindfulness. So those of you who may not know what Kaizen is, it's a practice of learning and behaving in order to make change. And she talked about mindfulness and the fact of if you can't take a deep breath every morning, take a deep breath once a week. Start there and then build from that. So the idea of small changes adding up to something much larger. So thank you for teaching me that. Right. And I'd like to close with asking Dr. Rayudu to come say some closing reflections.
Hope she uses this picture forever. My wife. Well, I'll keep it brief. I graduated here 10 to 15 years ago, and I want to say so humbly that I am so impressed. So the terms you guys are using, the fishbone and the run chart, and so I've never heard those words when I was in school. And so that's, things are changing rapidly. That's thanks to Dr. Dries, Dr. Jackson, a lot of your mentors for giving you these skills. And I hope, as you graduate medical school, as you graduate residency, keep in mind that a lot of these opportunities that you're being given are kind of a little bit unique to academic medicine. And some of you may end up there, some of you may not, but I hope you'll take these ideas and these skills that you've learned and take it with you into your practice wherever you go, because it's really important and it really affects every patient that you take care of. And someday someone will be breathing on your neck to say, how many cataract surgeries did you do today? And that's going to be their bottom line, but hopefully you'll remember that there are so many components of taking care of patients that you're learning now that you can carry with you. And I'm just, again, very impressed by all of you and thankful that you all are doing this work.
And I'm over time because I talk too much, even with it scripted. So we want to have a really warm round of applause for our keynote presenter, Dr. Julie Orley. Thank you. I want to thank our platform presentation moderator, Dr. Kevin Orley. We have many advisory committee members here in this room who support this work from many institutions within the city who support the School of Medicine and these endeavors. And this work really wouldn't be possible without that level of senior leadership. And so I thank you all, and you'll have some more from Dr. Safley here in a few minutes. And thank you, Dr. Safley, for chairing our advisory committee. And in case you just didn't already know it, I have to thank Ms. Sari Cantrell for her work, her boots on the ground, her attention to detail, her passion for the work, and her continuous improvement mindset to make this better every year. So those of you who know this program from 5 years ago when we started this work can clearly see the difference in how we operate and how we conduct this program. So thank you. Sorry. What better time to promote next year's event than this year's event? So please hold the date for Friday, May 2nd. We have a wonderful keynote speaker, Brian Wong, coming to talk to us from Toronto. All right, so that concludes the general program. If you are a part of the advisory committee meeting and you're sticking around, please stay in this room. We have a short break. I'm allowing you 10 minutes instead of the 15 you were promised. I know we'll have many more online on our Zoom, But for the rest of you, thank you very much, and we hope to continue to see you do this change work. Anyone we asked to stay after, please huddle around. I think, sorry, we have a list. We're going to start doing some of those. So let's start with platform presenters, with the 4 platform presenters. Come up here.
Yeah.